I'd like to thank everybody for joining today. Today's meeting is about how computed tomography can improve case management for practice and pet owners at mobile pet imaging. My name is Ron Tibbett. I'm the Vice President of Sales for Epica Animal Health. For those of you who are not familiar with Epica Animal Health, we manufacture and build high-definition volumetric imaging platforms to enhance diagnostic accuracy, improve diagnostic confidence, and help the veterinary community provide better and more clear answers to their patients. Our company's dedication to innovation and engineering has earned us multiple patents, as well as the trust of many well-known research and educational institutions, leading veterinary hospitals and specialty groups during the last 10 years. Over 300 plus progressive veterinary hospitals now use our imaging system and regard high-definition volumetric imaging as a new standard of care. I'm joined by Dr. Pedro Armstrong, boarded internal medicine specialist. Dr. Armstrong was born and raised in San Juan, Puerto Rico. He attended Iowa State University for pre-veterinary studies. In 1996, he was admitted to Tuskegee University School of Veterinary Medicine and graduated in 2000. Following veterinary school, Dr. Armstrong did 1-year veterinary internship in VCA, West Los Angeles Animal Hospital. In 2001, on the mentorship of Dr. Mark Hitt, boarded internal medicine specialist, he completed a 3-year internal medicine residency, at the AVIM in Annapolis, Maryland in 2008. He co-founded the Southeast Veterinary Referral Center and the Pet Emergency Room in Miami, which he sold in 2016. In June of 2014, Dr. Armstrong partnered with Dr. Xavier Mo to form Mobile Pet Imaging, a revolutionary mobile high-definition CAT scan and fluoroscopy service. In 2016, Dr. Armstrong founded the Veterinary Internal Medicine Group, providing internal medicine mobile services throughout Broward, Miami-Dade, and Monroe counties. Dr. Armstrong is interested in endoscopic procedures, gastrointestinal and respiratory imaging techniques, abdominal ultrasound, CT scanning, and non-invasive procedures such as ultrasound-guided biopsies. He has a special interest in conditions affecting the gastrointestinal tract, stomach, intestines, liver, pancreas, urinary system, and endocrine system, diabetes, Addison's disease, Cushing's disease, etc. Dr. Armstrong has lectured on topics of veterinary internal medicine. In addition to attending yearly meetings, for specialists, Dr. Armstrong has attended advanced courses designed for internal medicine specialists to learn about new procedures, new techniques, and new therapies. He also is also a member of the Comparative Gastrointestinal Society. Dr. Armstrong is fluent in English and Spanish. He is also the proud father of 3 and enjoys boating, fishing, biking, and swimming. Before we get started, I'd like to take a couple of minutes for housekeeping items. This talk is pending approval for 1 CE credit, and all qualified attendees will receive their certificates in the next weeks. There will be a survey with 5 questions that will run after this webinar. Your answers are required to determine your eligibility for race credits. This webinar is recorded, and we will provide a link to the recording within the next few days. You're more than welcome to submit your questions to the Q&A box at the bottom of your screen, but you will also be able to do that at the end of this webinar when the Q&A session opens. Without further ado, my friend, Dr. Armstrong.
Mm-hmm. Thank you, Ron, and thank you, Epica, for this opportunity. As Ron said, mostly I'm doing nowadays, the mobile CT, which we're going to talk about today, and then I'm also, doing mobile ultrasounds and internal medicine consult. But today specifically, I am super excited because every time I get to speak about this and about the role that CT can bring to your practice, it is, I think, an opportunity for me to open your eyes up and see the benefit of CT, see what it brings to the table. And the way we're going to do that today is we'll talk about, some of the indications. We're going to talk about the difference between CT and ultrasound, and CT and X-rays to help you guide you when you're doing that, that diagnostic workup, what would be the best imaging modality for the case that you're working on at that time. And then finally, we're going to go over some of the cases that we've seen and apply the knowledge and the lessons from real life cases. These are cases we see, and we've seen multiple cases similar like this, like the ones I'm going to present. So this is amazing because this will open up, hopefully will open up your eyes as far as the world of CT and how you can implement it in your practice, and more than anything, how it can benefit your patients and how can you diagnose faster, which is what we try to do. I would like to start the presentation with this slide. You may be wondering why there's a Starbucks, but that's back in September of 2013. Ron Tibbett told me about this new company that was coming up with a smaller CT. I had been planning to do a mobile CT or a CT center, but this, the traditional CTs are too big. And we met at that Starbucks in South Miami. That's across the street from University of Miami. And I met with Ron, and that's when I met Greg, who's the founder of Epica. And what's amazing from that meeting is that they took a risk with me. We were both, in a way, startups. They were starting to sell CTs. They were already, in production, and I was had an idea. So they took a risk with me, and by putting this, expensive, delicate machine on a truck, on a mobile unit. I don't know if that was part of what they were thinking when they were designing it, but they said, let's do it and we'll back you up. And they did. Not only they did, a year later, we were on the road. I think 6 or 8 months after we started, they actually replaced the machine completely because they have found ways to upgrade it and make it better. And they literally swapped a brand new machine after we had it for, I remember, 8 to 12 months, and we got a brand new upgraded machine. So that's something that I think you guys should consider when you're looking at purchasing the different. You have a lot of options out there, but I think Epica is different in the sense that way I see Epica versus other companies is that they saw the problem in veterinary medicine that CTs were not prevalent, and they're trying to solve it. And they're not so much worried into the numbers and sales. They're, what I see from Greg and Ron and the team is, we're more worried about solving the problem that we have, and then hopefully everything else will sort itself out. To the point that, as it says there, we're up to like 60 to 80 scans a month. We've been very successful. In South Florida, we've been on the road since 2014. So that's 8 years. And then 2 months ago, we started our second mobile unit in the Central Florida. So we're covering Orlando, Tampa, the villages, the East Coast. So we're pretty excited. So hopefully we'll keep, expanding as well and spreading this message of CT, which I think is going to benefit many patients. And through Epica, in our case, thousands of patients have been benefited that otherwise would have gotten a scan because A, wasn't available, or B, was too expensive. So we've been through, together with Epica, we've been able to help all those pets as well. So let's move forward. I'm just going to talk to you a little bit about cool cases we've done. Just to start the lecture, not on a boring part, like also didactic. We'll talk a little bit of some of the cases. Ron wanted me also to show you guys some of the things where we've been featured, in local TV and radio. We've been on print and web. That's the Komodo Dragon. You'll see a little video later about it. Of course, 95% of our patients are dogs and cats, but the exotics are the ones that get the attention. So we've been also on national TV with Nat Geo with Dr. K. We're her CT provider. And so we've done multiple cases with Dr. K and being on their show. So that has been a lot of fun. That's mostly my partner. I just do this type of stuff, the not so fun stuff. And he's always on TV or being featured in some newspaper or something. But we both do, I guess we do a good job of what we do. So we also, because my understanding that there's some people that work in zoos facility or animal facilities, we also service, and this has been, for us, it's been amazing, but it's a good symbiotic relationship because for those of you in the zoo, that at least locally, what they were doing is they were sedating the animals or anesthetizing them, taking them to a human facility to be scanned and then brought back to the zoo, anesthetized and then recovered. So it was a long anesthesia period. As you know, the risk increased with the time. So now we were able to go to them. We did the koala, the aardvark. All this is at the Miami Zoo. We did a pygmy hippo. That was pretty cool case. Had a cleft palate. So we diagnosed the cleft palate. and he did very well. So Zoo Miami is very happy with this opportunity they have now, where we go to them instead of them having to send the patients out to a facility. That's Dr. K. We actually, part of the Zoo Miami too, we were part of a study where they were looking at the size of livers in stingrays and comparing them in captivity versus they already had acquired the normal size of livers out in the wild. So that was pretty cool. I think ended up being an abstract at ACVR in 2020 by Dr. Jimmy Johnson. And so that was a nice opportunity and a nice experience that we had moving forward and being part of this study. That was definitely different. There's an albino croc that we did at what used to be Jungle Island or Parajungle. I think it changes names every now and then, but it's in Miami, and this one had a nasal tumor. This is actually a pretty cool case too. I think this may be the first CT on a Komodo Dragon, and we have a little video. I'm not gonna play the whole thing, but we did this at Palm Beach Zoo, and she's doing very well. Let me play the video a little bit so you guys can see. We'll play 1 or 2 minutes, so at least you can see how it goes in the truck.
What's the area of interest? This whole area? Within the legs, we probably need to. Area of interest is probably here. Okay, perfect. I think the reason is interest. And then how to be on here on there. And then, Doc, you want to.
So I don't know how many of you guys know more about Komodo dragons, but when they eat, they launch back, they swing their neck up to be able to swallow, and she wasn't doing it. And we actually diagnosed arthritis of the cervical spine, and she actually got electroacupuncture. So so that was something, and my understanding, I have, this was like 4 or 5 years ago. We haven't heard much since then, but that it was doing well. Let me play a little bit more, and then we'll keep going. That also gives you a good idea of what our mobile unit looks like and where we have the Vimago installed. And, that's a whole setup that we have at this point. Okay, if you guys want to see more of that video, there is the whole video is in our website, mobilepetimaging.com, and there's a section on videos, and there's that video and other videos we've done. This picture I like to include it because it's a pretty cool picture as far as the people in there. This is our local cardiologist, Dr. Carpenter, placing a pacemaker, and with that we use the fluoro part of the machine, and we've done multiple of those. He also put some tracheal stents, PDA coils. So he's another one that has benefited from having this this technology on a mobile and available to him, because now he can practice all these procedures that otherwise he wouldn't be able to practice. Back then, with the thumbs up, is our technician Rob. He's been with us for a long time. So the question is, when should you go for a CT scan? That's also the first question that I got when I started with this. The vets were asking me, when should I go for a CT scan? What are the indications? There are over 100 indications that can benefit from my CT scan. And so today, we're going to spend at least 20, 30 minutes in each of them. So, by 6 o'clock, you should be, no, I'm just kidding. But there's, like I said, there's 100 indications of CT scan. In our website for our advertising, we kind of, came up with the most important one. We tried to create a summary of the indications. I believe all this is in the website as well. But for this purpose, we have a top 9. We have our top 9, and that's what I want to go through with you, because these are the things that I want you to start thinking CT scan when you see cases like this. And you've probably seen cases, so I want you to go back to cases that you're already managing it and think if a CT scan will be able to, to benefit that patient. So our first indication is nasal discharge. We do a ton of skulls, okay, skull CTs. Nasal discharge is a very common, doesn't matter dog or cat, doesn't matter the age. We've diagnosed severe rhinitis in 8-month-old kittens. And it's impressive. You will never know how much damage there is in the turbiness, in the passages, without doing a CT scan and getting a great idea of the extent of the disease. And that's one of the things that I'm going to be hammering today. I'm not only going to talk about how CT can diagnose a condition, I'm also going to tell you, which is almost as important, is it tells you the extent of that condition. And that is, like I said, almost as crucial as the diagnosis itself, because it allows you to come up with a plan to see if there's even a plan. So anything with nasal discharge, unilateral, bilateral, hemorrhagic, or purulent, CT scan should be something that you should be thinking about. It also allows you to plan rhinoscopies, okay? Not every nasal discharge has nasal problems. A lot of them are in the sinuses. So if they're in the sinuses, there's no business in doing that endoscopy. You have to do another approach. So that's another thing that the CT does. It allows you to plan what the next step will be. Would it be a culture? Would it be a blind biopsy? Would it be a rhinoscopy? Would it be trephination? What would it be? So that's what X-rays will never give you that information. CT does. The second one is liver disease. And by liver disease, I mostly mean vascular disease, such as shunts, either acquired or congenital. The shunts are very difficult to see on ultrasound. I've sent to many radiologists, and they swear they can see them and they miss them. Some really good radiologists could potentially pick a bunch of them up, but out in the real world, mobile, we don't, going to clinics, we don't have radiologists with $250,000 ultrasound machine to do this. We have to diagnose them as soon as we can so we can treat them. I think CT is a gold standard for for detecting shunts, definitely congenital, and for acquired, for the chronic hepatopathies, you're never gonna see them. You're not never, but even radiologists will tell you you're not gonna see the acquired shunting on ultrasound. So definitely CT will allow you to give prognostic information on those chronic hepatopathies, because if there's acquired shunting already present, that will make the prognosis worse. But for portosystemic shunts, definitely think CT. There's a few cases where we've actually diagnosed 2 different shunts on the same patient. That probably would have been missed on ultrasound. So definitely think CT for liver shunts. So one of the things that we put together, and this is on our website as well, I created this flow chart to help veterinarians decide what imaging modality would be beneficial in cases of liver disease or elevated liver enzymes. And let me see, laser pointer. I'm hoping you can see this. Veronica, can you let me know by text if you can see the pointer? But so that, you start with elevated liver enzymes. Definitely, if it doesn't respond to denamarin, do your bile acid profile, and then the bile acids will be the first determining factor. Okay, if the bile acids are over 100, you go straight to CT. Okay, if your bile acids are normal, I think it's okay to do an abdominal ultrasound. But then if bile acids are between 30 and 100, you do your protein C activity level. And this is very important for you guys to know this. The protein C activity level is an anticoagulant, and research has found that if the activity of that protein is over 70%, a portosystemic shunt is highly unlikely. So you can go to ultrasound on those cases. But if the protein C activity is less than 70%, then you can't, a shunt is possible. So that's when you go to CT scan. So this is a flow chart that I kind of put together to highlight the facts that we look into, the factors that we look into when determining CT versus ultrasound. Chronic ear disease, another huge condition. We'll of course, we'll have cases of the liver shunt, and we'll have cases of otitis. Very common indication that we do. All these chronic ears that don't get better, that you've been treating, do a CT. There's a lot of disease down in the bullous that you don't know about. Narrowing of the canals. There's a lot of things, and then it will definitely help the surgeon plan the surgery if they're going to do some type of, bulosteotomy or whatever they're going to do to try to alleviate the condition in that patient. Unexplained lameness, we're not going to talk about your regular lameness. We can diagnose, I would say, a big % of them. Don't ask me any questions about lameness. I'm an internist. Thank you very much. But there are some lamenesses that I'm told that are difficult to diagnose: the shoulder, the elbow. So a lot of the things in those joints, sometimes hips, will definitely benefit from a CT. We do a lot of shoulders and elbows when they cannot, pinpoint the joint, or they want to get an idea of the OCD or anything. So unexplained lameness that, you've done your x-rays, you've done your exam, and you can get to the bottom of it, definitely be thinking CT. Issues regarding surgery, like I talked earlier, we're going to be talking about the extent. So one of the huge advantages of CT is that it lets you plan surgery. It tells you if the tumor is resectable or not resectable, because we're giving IV contrast and we know where the vessels are going into. So definitely, when you're trying to plan some type of surgery, abdominal, like I use that a lot for adrenal masses, any intrapelvic masses, very, very large liver masses that I think they may be wrapping around the major vessels, definitely a CT should be considered. A splenectomy? No, I don't think so. A single solitary intestinal mass? I don't think so. But definitely those complex surgeries, biliary surgery, I think definitely pancreatic surgery should definitely be preceded by a CT scan. Anything in the thorax should be preceded by a CT scan. I'm going to show you a case later about how CT help plan the surgery and where to perform the surgery in that patient. So definitely intrathoracic, consider CT. X-rays are very poor. They'll give you obvious changes, but they're not going to show you minor metastases, minor smaller nodules, and we'll talk about them in a little bit. Weight loss, any consideration of weight loss. If you're not, maybe you did an ultrasound already, but I think on a general basis, weight loss, almost like the med check too. I think that should be CT, chest and abdomen. If you diagnose some type of muscle tumor in the leg, I would do a CT of the chest and abdomen, because not only the CT is giving you the soft tissue, which you get with the ultrasound, but it also gives you the bony tissues. So then you can, the bony structure, so you can go ahead and see if there's any metastasis in the bones. And also, once again, the nodules in the lungs, you're going to see them a lot earlier on CT than on X-rays. Unexplained lumps. This is a big one. We've had multiple cases. This is a very cool. This is, I hope you can see it by here, by rib 3. This is where there was like some type of lump here. Okay, that's all it was. And so what it ended up being is a grass on that migrated from the thorax into the liver, into the abdomen. And this is the track of the migration. It is, it's an amazing case. So this will give you, is what I call, what everybody calls the iceberg effect. You see a little lump. We have one the other day too. And inside, underneath it, is just a huge mass that there's not much to do. So that would be, I want you to start thinking CT with unexplained lumps as well. Persistent coughing. If your x-rays are good and the patient's still coughing, think CT. You're going to see so many things. I have a case to show you. You're going to see so many things that that x-rays will not show you. So definitely when you have these dogs that are coughing, then they're not responding, you ruled out the obvious. I would definitely consider tomography for this purpose. Dental disease. I'm sure you guys get a lot of, if you're here, you get a lot of EPICA emails about dental. This is a huge indication. This is a huge indication. I'm going to show you a case there that otherwise wouldn't have been diagnosed other than CT. I'm not saying that x-rays do not have a role in dentistry. I think they do, but definitely on the more complicated, especially the more proximal caudal, you get, I think CT will give you, better images than x-rays. I think x-rays, they do very well with rostral, the most rostral dentition, but as far as going caudal, I think CT definitely takes the cake. So now, I mean, those were our 9 top indications for thinking, CT. Now let's go over advantages of CT versus ultrasound. So once again, when you're thinking of a case, you need to start thinking now that CT is a possibility. Is CT a possibility in this case, or do I stick with ultrasound? So in cases where you're going to be thinking about CT will give you more accurate in many areas, okay? For example, liver shunts. Liver shunts are hard to see on ultrasound. I gave up looking for them probably like 15 years ago. Even radiologists miss them. The good ones maybe picking them up 60, 70%, but that's all they do. In the real world, we don't just look at shunts, and also gives you the origin point. It gives you the insertion point. A lot of times you don't get that with ultrasound. It gives you other potential abnormalities as far as, if there's a second shunt, or you'll see other findings that we get that when we scan patients with liver shunts. Pre-surgical planning, 3D evaluation, we talked about this. I try to send to CT all of my adrenal masses. Definitely the adrenal masses, I always recommend, or I strongly feel that they need to be scanned to make sure that the adrenal is resectable. The way I talk to the owners, and this is very important, because it all comes down to your conversation. It's not resectable, and we close them. Most owners don't want their pets to go through that. The other thing it will give you a great metastatic evaluation that x-rays will not give you. So if the nodules in the lungs, there's mets in the lungs, and they're like 4 millimeters, you're not going to see those on x-rays. You're going to see them on x-rays when they're 9 or 10 millimeters. On CT, you'll see them at 1 to 2 millimeters. So you see them a lot sooner. Even though it's bad news if we find metastatic disease, the owners understand, because we didn't put their pet through an unneeded surgery that otherwise without a CT, and maybe they would have taken 3 view chest x-rays and it was clean. They would have done the surgery, and then 2 months later there would have been mets showing up. And those owners prefer to have as much information. It's not always possible. Of course, we have to work within the confines of finances, but I'm just telling you that if you're thinking a dog may have an adrenal mass, an old dog, a large breed dog that suddenly starts showing symptoms of Cushing's, those large breed dogs a lot of times have masses. The little white dogs are the ones that get the PDH, but these bigger dogs have masses. It wouldn't be a bad idea in my eyes to send them to CT instead of ultrasound, because if you have a mass, you already know if it's resectable or not. So those are things to keep in mind. Structures in the pelvic canal, huge indications. Ultrasound don't get it there. You see part of the prostate, but you cannot get much caudal than that. Depending if the bladder is pelvic, a lot of times you don't see a lot. But when you have any abnormalities, colonic, lymph nodes, definitely CT will trump ultrasound. Spinal compression, evaluation of the spine. The reason I put that here, you're probably wondering, why would I evaluate the spine versus with the ultrasound? No, but we all seen these patients that have pain in the abdomen, and we don't know if it's referred pain from the spine or if it's primary abdominal pain. Typically for those guys, we do an abdominal ultrasound, but once again, the ultrasound does not evaluate the spine. So we've seen these dogs with kind of a pain of unknown origin, and we scan them, and the abdomens are fine, but we do see changes in the spine. So definitely that's something to consider if you have a dog that maybe even you already did an ultrasound, to consider a CT. Ectopic ureters, another huge one. CT is invaluable for this condition. A lot of times, or almost never, you'll pick it up on ultrasound. But this is one common condition that we pick CT over ultrasound, because we do this probably once or twice a month. Now, and all this I'm telling you is not just me trying to sell you something, because I'm not trying to sell you anything. I'm just trying to tell you indications. But there's a study right there. When you have a dog over 50 pounds, 25 kilos, the studies say you should go to CT. Okay, the sensitivity of ultrasound drops when you start getting that big, and that makes sense. You know, when we are scanned, when we need our abdomen scanned, they don't go to ultrasound, they go to CT. The bigger you get, the bigger the dogs are, the ultrasound becomes more challenging. So, you know, this is true, you know, data that should guide you what to do with those patients as long as the owners can afford it. And before I keep going in the theme of affording it, another thing that I would like for you guys to start thinking is, I mean, I think there's people from all over the world here, but where it's available, consider insurance, consider pushing for insurance in your pets, because those are your best, those are going to be your best clients. Those are our best clients. Those clinics that push for insurance, they call us all the time because the owners have no constraints, no financial constraints. You should be pushing for insurance, with the intent, I don't know the whole politics behind it, but with the intent of being able to practice the best medicine you can practice without financial constraints. So that's something that I wanted to include here. So now we talked about the ultrasound versus CT. Let's talk about CT versus X-rays. So here on the X-ray, we see what could be a renal mass. But on CT, it shows you an adrenal mass. This is of course, this is an excessive example, but it's a real life example. You know, it did happen. You know, maybe someone will say, oh, you have a renal mass, you know, and they'll come up with some type of prognosis. But here you see an adrenal mass, the prognosis changes.
Pedro, I think you've lost sound for that last slide. So if you could go over that real quick, please.
Over this one?
Yes, this last slide. You just lost sound. Sorry.
Can you see a pointer? The red pointer?
Yes, you can see the red pointer. It's a little bit slowed down.
Okay, so here, I mean, this is an X-ray. I was told that I lost sound. So this is an X-ray of what looks to be a renal mass, a kidney mass. But of course, when you do a CT, it shows you that it's an adrenal mass. It's an exaggerated example, but it's still a real life example. And, you know, on the X-ray, you could potentially think you have a renal mass and that has a prognosis, but the adrenal mass of that size will have a completely different prognosis. Same thing with the skull X-rays. We all know that, you know, the pain that skull X-rays cause, taking skull X-rays to our staff, it causes. We need to stop that. There's no need to take skull X-rays. I mean, you can see here in this area, we don't know what we see, and there's a big mass in there. I mean, it's night and day. I mean, you should not, unless the owners have no, of course, I mean, finances will play a role, but if they're able to afford this, it is your duty to offer it. I mean, they're willing to, for those of the ones that are willing to pay for the best diagnostics, you need to offer it to them. And that would be to the pet's best interest down the road. An X-ray, IBDD, CT, discal spondylitis. How many IBDD we have diagnosed with pain in the back, okay, on X-rays? Well, some of them have discal spondylitis, okay? So those, they need antibiotic. Once again, I'm not trying to make you feel bad. I did all these mistakes myself too. It's just trying to raise some awareness. Pulmonary metastatic disease, I touched on this already. Not much going on here. This dog had multiple nodules in the 4 to 6 millimeter range, and you wouldn't see them on X-rays. And if you see them, you wouldn't be sure if they're a nodule or not. On CT, you're sure. There's no question. And we can't forget, we always forget our red-headed stepchild, fluoroscopy. We always like to talk about tomography, but fluoroscopy is an amazing tool. So this is a swallow study. Before I purchased this machine in 2014, I myself have never seen a swallow study. So don't feel bad if you haven't seen this, if this is your first one. But here in slow motion, you see the kibble. And I'll talk more a little bit how we do this. We have a case about it. So that's the kibble. For those of owners that they think that the dogs, they break and they chew the kibbles. No, they don't. They just organize them into a little train, into a little chain, and then down they go. This is actually, no, this one. It's actually, I think everybody will enjoy. I think anyone, even pet owners, make the diagnosis right here. So I'll let it play. There you go. Let's do it one more time. So that's barium going down and shooting back up. That's reflux, okay? Just wonder how impressed this owner will be. Probably that dog has been regurgitating or licking its chops or even vomiting for months. They probably did a bunch of x-rays, ultrasound, none of that will diagnose it. You do a fluoro, in less than 5 minutes, you have a diagnosis. And this is awake, okay? Just imagine how happy that owner will be and how happy that pet will be, because now we'll finally get some relief from the pain of the reflux. Okay, so I hope that kind of summarize to you like the indications and when to pick one modality over others. Let's run through some cases. I have 10 or 12 cases. I mean, we don't have to go through all of them, but let's see how far we get. Before I go in, I want you to do this, especially the ones that have a CT or they have access to a CT. You need to put this on your X-ray request forms from now on, every X-ray request form. And you need to call the companies that you send X-rays to tell them that you have access to CT. What happens, what we've learned is that a lot of radiologists, they assume nobody has access to CT. So they're not even recommending it, even on conditions that obviously the CT is indicated. They just make this assumption that nobody has it. So you need to let your radiologist know, I have access to CT and fluoroscopy. And even if you're thinking of buying a CT, let them know. That way you start seeing the cases that they will recommend a CT. It may give you a good idea of the volume that you may use it. But for those of you who have it available, I strongly recommend you let your radiologist know that you have CT and fluoroscopy available. So the first case is a lab mix, 8-year-old male neutered, presented for not eating, drooling from the left, and I had a droopy left eye. Skull x-rays were not, of course, diagnostic, so they recommended skull CT. Physical exam, he was painful at the base of the left ear, had an inflamed canal, and the eardrum was not visualized. Of course, skull x-rays had no significant findings. We all know that. We should never take them again. Pre-op lab work revealed slight monocytosis, nothing there. So this is every case will have this slide, but I skipped it for every case because it's just repetitive. But just so you know, all the anesthetic protocols in our case were designed by our board certified anesthesiologist consultant. And the CT scan, we only use Omnipaque. We use the brand name only because we're mobile and we want to try to minimize reactions. That's why we don't use the generic forms. I'm sure they're fine. It's just that, once again, just because we're mobile, I'd rather go with the brand name. So here we go. This is our skull, okay? The beauty of CT sometimes is like an open book, right? You have on one side, on most parts of the body, you can compare to the other side. Here we have a normal area bulla. We have a nice ear canal, and you can see right away, this is not the same, okay? Fluid filled, the canal is super narrowed, okay? This is the axial view, okay? And you're going at 2 different levels. This is your coronal, you're looking from the top, okay? Here you see the normal bulla right here, and then you have the abnormal fluid filled bulla. So what did the radiologist report? By the way, everything is read by board certified radiologists. That's another thing that, for those of you who have CT, make sure you screen your radiologist. Not every radiologist are good at CT. I'm not saying they're not great at MRI and ultrasound, x-rays, whatever, but not every radiologist should be reading CT. The findings are severe left otitis media, bilateral chronic otitis externa, and left medial retropharyngeal lymphadenopathy. So all the changes were likely secondary to chronic inflammation. Neoplasia is possible, but highly unlikely, okay? And all those swelling explain the facial facial nerve abnormalities. So the follow-up surgical consultation. So how did CT help in this case? It identified the disease, but not only identified it, and this is important, I'm gonna keep pounding on this, demonstrated that its extent, okay? Now we know what part of the canal is affected. So for anything ear disease as well as dental disease, you need to consider CT, okay? You're never gonna get that on x-rays or even an otoscopic evaluation. Second case is a 3-year-old female German Shepherd with chronic left nasal discharge. I picked this case specifically because the findings are very focal, are very small. So this is kind of an exception. We normally see much more dramatic changes, and I'll show you some pictures or some images with those. But this one was specifically picked because the changes are minimal, and so it definitely shows the capacity of the Vimago. So physical exam, unremarkable. Diagnostic prior to nasal CT, unremarkable as well, which is the typical of what we see. So in this case, let me go to the next slide because you'll see everything better. So the problem is this area. No X-ray will ever show you this, and maybe other CTs will even miss it. So you see your turbinates and everything, and then you see the problem there, okay? And on the axial, we have it there, okay? So that is huge. That's why you want CT over X-ray. You will never pick anything up on X-rays on this patient. So focal left-sided turbinate lysis without evidence of a mass or foreign body, okay? It could be potentially fungal rhinitis, which is what ended up being on fungal culture. Other possibilities, as it says there, neoplasia, inflammation are less likely because, it's just very localized, and there's not a lot of inflammation around it. You also, the radiologist also reported dental changes, okay? So once again, we're getting an incidental finding, we're getting more information on that patient. Plan follow-up, clotrimazole infusion treatment, and it will have one more treatment. At that point, it was going to have one more treatment and then rescan, but we lost them to follow up. And my guess is that it did very well with the one infusion and didn't come back for the follow-up. But here's the kicker. Here's what you need to learn. Number one, discover the focal change and the extent. But also very important, you have an intact, it told you that you have an intact cribriform plate. So now you can do the clotrimazole infusion. If you do those localized infusions and the cribriform plate is affected, the infusion, the clotrimazole is going to leak into the brain, and that's going to cause problems. It has been reported. So the CT not only gives you the diagnosis, the extent, but also if you're able to perform the recommended treatment. Okay. And once again, incidental finding, dental lesion. Does anybody have any questions? Oh, let me go through this really quick. These are more severe, more obvious changes, which is what we typically see. Once again, this is more like a normal structure, and here you see a big mass. These are the most common changes. Once again, you're going to see this on X-ray more than likely on most X-rays. If you're lucky on an oblique view, but we don't have to deal with that. And so those are the most common obvious changes we see. In this case, look at this, it was midline, and then here, it just broke midline. So no, the information you get on CT on the skull, it blows your mind. You're gonna wonder how come I practice medicine without a CT. If anyone has any questions, I don't know if they want to type them, or do you want me to keep going, Victoria?
Yes, you can keep going. Let me
What
check
time do you want me to stop?
We can keep. Ron, do you want to
Pedro, we're good. And the questions are, when people have them, they can write them down in the chat area. There's already one question. We'll come back to them later when you're completed. Okay?
Okay, perfect. So I'll keep going. Third case, 6-month-old female domestic shorthair was referred for a CT angiography. This is our first shunt case. This was a very neat case. The kitten wasn't growing as expected and also had copper colored irises. And as we know, a lot of the cats with shunts have copper colored irises. It's something that should trigger you to think when you see that on a kitty. Prior to angiography, blood work wasn't remarkable, which is typical. Not always the ALT is elevated. And the bile acids profile was through the roof. You know, preprandial 206, postprandial 209. In this lab, normal was up to 20. So here in this case, you'll see the shunt right here. Okay, this is a normal vessel. This is on the coronal two-dimensional view, and this is a three-dimensional, the shunt over here on the right. I hope you can see the pointer. I have a quick video, and you'll see the shunt coming up. Dorsal, I mean, here at the top of this, almost at the top of the screen. Play one more time. This is a 7-looking vessel. So what did they find? They found a single extrahepatic portosystemic shunt. On CT, we can tell where it starts and where it ends, splenophrenic. Bilateral renomegaly, which sometimes you see it to the shunt, secondary to a shunt. And then they did surgical correction. And the patient at that point was doing well on lactulose. I'm sure by now there's no lactulose. But what was really cool about this case is because the cat was so small, the surgeon had to wait like 4 or 5 months for it to grow a little bit more to be able to do the surgery. And then this is the shunt right here. And this is an intra-op picture. And then the ameroid constrictor occluding the shunt. You can see that there. So how did CT help in this case? We got a diagnosis. Nothing else would have given it to you. I challenge anyone to do an ultrasound on a 2-pound cat to find a shunt. And then you got surgical planning, 3D reconstruction, and 3D printing. One of the things that we're hoping to incorporate in our future is 3D printing. We actually 3D printed that shunt. But in the future, for more complex surgeries, you could 3D print the CT to plan surgeries, either like a complex pelvic fracture, the valgus deformities, those kind of conditions may benefit from 3D printing. My understanding, and Ron can correct me, is that Epica has this option. If you have a study, you can 3D print it, I believe overnight or within 2 or 3 days. They'll send it to you, and it's very reasonable. Once again, I just want to revisit the flow chart of for the liver enzymes. In this case, the bile acids were over 100. Okay, they were in the 200, so we went straight to abdominal CT scan. The fourth case is a Sharpei. This is going to be our fluoroscopy case, which is pretty cool. It's a 7-month-old female Sharpei, chronic regurgitation and vomiting. Exam wasn't remarkable. Prior to the esophagogram, they went ahead and did blood work. No abnormalities there. Thyroid panel, resting cortisol, and thoracic x-rays were normal. This case was, to me, neat because I learned something with the case. For the esophagograms, and that's what I was referring to earlier. So one of the coolest thing of this machine, of the Epica, is that it allows you to do your fluoro, the tracheas and the esophagus on their natural position. Normally on fluoros, the ones that have worked with the C-arm, you literally pin the dog down on the table, on the x-ray table, and feed him. That's not natural, okay? So definitely these dogs are just, and cats are just sitting, okay? You're feeding them. We try to do it mostly in dogs. Cats are difficult. But the main point is that they're in their natural position. You don't have to pin them down. For the tracheas, for tracheal collapse studies, this is it's a dream.
Pedro, you lost sound again if you can hear us.
And that way we try to get the 3 phases on every case.
Pedro, can you go back and repeat that? You lost sound again for a second.
What was the last one you heard? Do you know? The whole slide?
Well, the second part of it, the back end.
Oh,
of
the phases. Okay, so for swallow studies, we do 3 phases. First, we give liquid barium, to evaluate how the esophagus works with liquid. Then we mix barium with canned food. That's the second phase. And then the third phase, we mix the kibble with the barium. And that's the one you guys saw earlier, where you saw the kibbles going down the esophagus. So this is the fluoro of this specific case. I hope you can see it. It's gonna be in the middle where the barium starts to accumulate, right there. Let me do it one more time. You see that one, it went well. And that's just a kibble. Sorry. And you see the kibble going down there. So let me show you this first part one more time. I'll pause it right here. So what you see in the middle that you didn't see on the canned food and the kibble, that accumulation, that caught my eye. But because we have amazing radiologists, that's a normal finding. So that was a learning experience for me. It's a normal study that focal dilation of the esophagus is a redundant esophagus, which can be a normal in young bulldogs and Shar-Pei breeds. So that was definitely a learning experience, and that's why you want to have radiologists that are very familiar with these imaging modalities. Follow up, they schedule endoscopy, and I do not know what was the outcome of endoscopy. My guess is, the dog was mostly vomiting, and then endoscopy was diagnostic. How fluoroscopy helped in this case? Oh my God, you rule out persistent right aortic arch. You ruled out megaesophagus. You ruled out sliding hiatal hernia, which is a very common condition, very difficult to diagnose on x-rays. It's almost like it is like the tracheal collapse. You have to catch it at the right moment. If it's sliding back, you're not going to see it on x-rays. We ruled out esophageal diverticulum, and we ruled out a motility disorder. There's no ultrasound or no x-ray that will ever give you that information. Fifth case, Boston Terrier, 14-week-old, very cool case too. This one, we had a major impact on this case, and we diagnosed it, but not only the diagnosis, and I'll go back to that, but this is a case that makes me feel so good about the prospect and the possibilities of CT and the impact it has on our patients. So Boston Terrier Pyothorax, physical exam. By the time we got to him, he had bilateral chest tubes. This was done at a referral center that at the time they didn't have a CT scan, so they were using us. Now they do have a CT scan. So they learned the value of having the in-house CT for them. So diagnostics done prior to CT, CBC cam, mild anemia, x-rays, just pleural effusion, nothing specific. Cytology was consistent with the pyothorax. We drained 25 mLs from the right side. And this is important because with CT, when you have intracavitary fluid accumulation, you want to drain it to be able to see the structures much better. That's one of the things prior to CT. If you have free fluid in any of the cavities, it needs to be drained, most of it. Findings, they found a right middle lung lobe abscess causing the reported pyothorax. There was right pneumothorax, no evidence of thoracic wall trauma or foreign body. There was a suspect left SHEF2 causing trauma to the left lung, and they saw cranial mediastinal lymphadenopathy, likely reactive. Once again, that lymphadenopathy, you're almost never going to see it on X-ray. Follow up, and this is where we had a big impact on this patient. Not only we diagnosed it, we found that the problem was on the right side. So we gave surgical landmarks to cut this patient. And the patient didn't have to undergo a sternotomy, which you guys know that is a lot more morbid than a thoracotomy on the right side. So here's a video on a coronal view. And here you see the abscess, you see all the gas pockets. and fluid pockets. Let me play it one more time. And you see a chest tubes. That's the right chest tube there. Those are the bright lines. Okay, so where I find that we help this patient the most is in selecting the surgery that that patient needed. Without a CT, they would have done a sternotomy on this patient because you don't know what site to go into. The CT allowed this patient to have a much better recovery, much faster recovery with a lateral thoracotomy rather than a sternotomy. And we staged and localized the disease. We found that it was only the right side. Nothing else in the chest needed to be evaluated. So we definitely, this patient benefited immensely from having a CT. The sixth case, we have an Airedale Terrier, 6-year-old female spayed, not feeling well, panting. Prior to CT, they had done CVC chem, unremarkable, and chest x-rays. They saw soft tissue opacity, cranial to the heart, which is a typical thing. There's something there. We need to look further, and that's where CT comes in. Okay, so now you see here that mass. So cranial mediastinal mass lesion and no evidence of pulmonary metastasis, and that's huge because with X-rays you don't know if the lymph nodes in the area of the mass are big. You don't know if there's other nodules. Now you know you only have to focus on that mass, and yes, of course, you have to stage the abdomen, and those were the recommendations. Ultrasound guided FNA sample or biopsy, and then abdominal imaging, CT or ultrasound to complete staging. So how CT helped in this case? No metastatic disease discovered in the thorax. It was a single solitary mass. Okay, it allowed you to see what the next step was, and it further defined the radiographic findings. The next case is a Frenchie with chronic unresponsive vestibular signs. He had a left-sided head tilt. It was circling to the left, and the diagnostic prior to the CT were unremarkable. So here you see, this is more like a normal ear canal and bullous, okay? And you can already tell that this is not like the other side. So you have ear canal narrowing, okay, both on the right and the left. So once again, I'm just trying to plant the seed, get you guys thinking about CT. I'm sure you guys have a lot of those difficult ear cases that they don't get better. So they found bilateral otitis media, no obvious, bone lysis was noted. Otitis interna is a possibility. They saw dental changes as well, a 301 incisor crown fracture with retained tooth, and then the stenosis of the canal. That's a dental finding. So in this patient, again, we established a diagnosis. We provided information for further diagnostics and therapy, what to do next, and then we have the incidental finding of the dental disease.
Hey, Pedro, it may be a good idea now to head in and start wrapping up and get some
Okay.
questions. There are some questions.
Yeah, because I know, I'll go to we can maybe we can do another one later, and then I'll just finish here,
We can definitely do another follow-up, Pedro, and do another, because I think there's a lot here, and we can definitely do another piece.
Yeah. So once again, I just wanted to finish with 3 slides. Most important thing, let your radiologist know you now have CT and fluoroscopy available. Okay, you need to let them know. If not, they're not going to recommend it, and you're not going to think of it. But you have the top 9 indications. You can go to any website and find a bunch of indications, and now you have this presentation also to think about it. One of the things that Epica was grateful enough to allow me to do is in our website, we also have this interactive ebook where we put together common conditions, and you can see it on the website. And those, we go from
You cut out again, Pedro.
most of them should be able to say yes to CT. Remember to push for insurance. Finally, one of the things that Epic allow me to do is part of what we do on mobile PET imaging is we provide what we call a license in case someone wants to start a mobile imaging business, CT imaging business, or even a brick and mortar. We can help you with the marketing, the procedure, getting your radiologist, doing the lectures. You know, you get all the support you need to get your business up and running faster and you know, much better. You're gonna be a much you know, the way you're gonna market it and talk to the vets is gonna be very thorough because you're gaining from our 7 years of experience. When you go mobile, you definitely have, you know, you beat the old way. The old way, we have all those problems that the pet owners have to do, take time off, make appointments, expensive. Then when you go mobile, we go to you. We go to you, it gets done, and it's done. For the owners, they just drop off and pick up in the afternoon. That's it. And with that, it's time to see more. But with doing mobile, this is your benefit. So I would like to wrap it up and open it up for questions.
Yeah, there are questions and I'll read them out. Pedro, great presentation and a great review of the system. So we appreciate your help on that. I'll start here. It says, if a pet owner signs up for pet insurance, how long is the waiting period before they can request a CT, particularly if it's a pre-existing condition?
I think that varies per insurance company. I don't know the answer to that question. I know some of them could be pre-existing, but if they're congenital, they're covered. Like a shunt will be covered. So that's something that you would have to inquire to the, you know, the companies that you work with. But I just wanted more than anything to create this because over the past year and a half, I mean, I wanted to say that because over the past year and a half, I've learned that most vets don't know that CTs are covered by insurance. So, so I wanted to, you know, put that in your mind but at that specific answer, I don't have it. That depends on the company.
I would agree with it. I think they should check with their own insurance company on what they cover and what they're, you know, when they covered as well. So I think that's good advice. The next question is, as a GP, would you be able to interpret dental issues? Myself, I do the necessary extractions or while under, or do I have to wait for the radiologist report?
I think that's something that with time, the person should be able to learn. Maybe at the beginning, it would be a good idea to maybe have them come the day before. I mean, that CT, if you're doing it on your practice, Ron will tell you that's a 15-minute CT. You know, I mean, you're going to induce them, do the skull, do contrast if you have to, and wake them up. And maybe at the beginning, you can do them the day prior, but I'm sure Epica has had that question 100 times, more than I have. Maybe Ron can answer it better.
No, I would tell you we have lots of clinics, obviously with over 300 systems, and many of the progressive general practices use exclusively the system for dentistry. And they can see exactly and interpret. It is a little bit different in the beginning, but with the three-dimensional view, especially when you get to reabsorption, it makes a huge difference whether you pull that tooth or not. Okay, Pedro, the next question. Do you have any positioning tips for swallow studies?
Well, that's the beauty of this machine. You don't have to position them. You just let them be natural. The person asking the question, do they have a Vimago or they have a C-arm and they're doing it on the side? I don't know if they can answer. But if they have the Vimago, they you know, we just either put them sternally or sitting up.
Yeah, if I can add to that
on the size.
Too, if the animal is small, you can actually just have them standing on the table as you do your swallow study.
Exactly.
If the animal's large, if you have the Vimago outside of the Pico model, then you would take the table off and you can actually have the dog stand or sit on the carriage. Just like Pedro had mentioned before, where they were sitting in a natural position. So that'd be my recommendation, is take the table off the Vimago and have them on the carriage.
Yeah, I myself never been involved in any swallow studies using a C-arm on the side, so I don't have an answer to that question. Damn, I don't have a lot of answers today, huh?
Oh, you're doing great, Pedro. Next question, could you see dynamic tracheal collapse on fluoroscopy?
Oh, yes, we do that a lot. That's a common tracheal fluoro we do. Maybe for the next one, I'll put a case. I don't think there's a case in our website. There may be, but yes, we do dynamic, that's how we diagnose it. And then also it allows you, it goes also together with the planning, because it helps the person plan the stenting.
Okay, moving on here. Somebody said
and case selection, I wanted to mention this. It allows you also for case selection, because if you have a lot of bronchial collapse, maybe the tracheal, you have to talk to that owner, because, the tracheal stenting may or may not help. It depends, since it shows you the extent of the disease, it helps you come up with a prognosis.
It looks like one of your clients down in Miami said, Pedro, I have to go. Thanks so much. Great presentation. So just here's another question for you, Victoria. Will the CE be emailed? I have to go to another meeting now.
Yes, since the presentation lasted a little bit longer than expected, I will email out the survey questions. And again, you have to submit the survey questions in order to get CE credit. So just keep that in mind.
Okay, Pedro, another in a chronic coughing case, would you perform a thoracic CT before considering a bronchioscope?
Yes. Do they still see my screen?
Yes, we can still see your screen.
So the answer is yes. Just like with nasal cases, you want to CT it before you do the bronchoscope, because it guides you where you're going. Okay, it definitely guides you. Let me show you this case really quick. X-rays were fine. Were normal, chronic cough, a thorough workup, and look at that. There's a mass in the bronchi. You need to CT them before, and we recommend not to scope them right away. You need to wait for the result, because you need the radiologist. You may see something on the CT yourself today, unless you feel comfortable. I don't, but I want to see the radiologist report. You may see something on the right middle lung lobe, but then the radiologist, and then you focus there on your bronchoscopy, but then the radiologist comes back the next day with left caudal changes that you didn't evaluate. So definitely you have to CT for chronic cough, and definitely for bronchoscopy, you should CT before, because it will guide your bronchoscopy, just like skull CT guides your rhinoscopy.
Okay, interesting question coming up next, Pedro. Is your mobile truck radiology protected against radiation?
No, because that's a feature. That's one of the many features of the Vimago, the low radiation emission. Not to talk about the lower, yearly maintenance plan and There's many benefits. The easiness of use, but the machine does not emit a lot of radiation. We do use glasses, thyroid vest. Of course, dosimeter, we've never been exposed higher. We are in the truck. We do push the patients to the back of the truck as much as we can, and we stand in the front of the truck when we're scanning, but we're there with them. And, this machine produces very low emission. I'm sure Ron can give you specific numbers.
Yes, in general, it's somewhere between 50 and 90% less than conventional CT, depending on what's being shot and the size of the animal. Pedro, here's a funny guy. Did Ron buy you coffee at Starbucks that day we met in your first slide? And sure enough, we lost you, Pedro. We lost your sound again.
Hello.
There you go. You're back, Pedro. So that
I'm back. Yeah, I guess I lost. Yeah, I was saying that I need to check my credit card statement.
No, we bought you coffee that day.
I know. I was kidding.
So all well, and we appreciate everybody for coming on. Hopefully that you were able to get stuff out of this. We will have this is recorded, so if you wanted to have this for yourself, we could, and we're definitely going to be able to bring Dr. Armstrong back for more cases and share some more information down the road. So we thank everybody today. Is there anything else, Victoria, you'd like to share?
No, but the email will be going out with a copy of the recording. And when I send over that recording on the landing page, when you arrive and follow the link, there will be the survey at the bottom of the page. So that will be the survey that you'll need to complete and fill out the form with your information and an email. And just remember that the email that you do use is the email that I will be sending your CE certificate to. So just make sure that that is a good email to contact you at. But other than that, excellent presentation. And thank you so much, everyone, for joining.
Thank you for coming, and thank you, Epica, for the opportunity.
Thank you again, Pedro. Fantastic. We really appreciate the support.
Thank you.